Be live in 3, 2, hold on, stay with me. Hold on, I want to make sure it's live before I start talking. All right, and we should officially be live right now. So I am here with Dr. Korn from 65 Plus Physical Therapy, and I just want to introduce him to our live Facebook Live audience. So Dr. Korn, welcome.
Hey, thank you, Dr. Torrance.
All right, great. And I have a really good bond with Dr. Korn. We've shared multiple patients. One of his patients found me, and then I just realized how great a work he does. So we're here tonight to talk things out and talk about a little bit of knee arthritis and what we can do to help on each side of the spectrum. And let me kind of start by saying, hey, Dr. Korn, so somebody comes into you that they've got some knee pain, some medial joint line pain. Start with like your initial workup. What do you typically do for your patients, and go from there?
Yeah, sure. Well, obviously, we're looking at how they're currently managing their condition at home, whether it be pain medication, supplements, exercise, things like that. We look at aggravating activities and things that make them feel better. And oftentimes, they are looking for me for advice on where to go next, even if it's beyond physical therapy. So one of the things I like about regenerative medicine is it's very complementary. I always say to my patients, rehab and regenerative medicine both start with R for a reason, because really we're trying to help you heal your own body, or your own body heal itself through various methods. I'm more of the physical medicine, you're more of the regenerative medicine. So we always start with aggravating features, aggravating activities, what they're doing for home management, and then go from there with more of a kinetic assessment, how they're moving, where that movement dysfunction is evolving from, how they're compensating, that kind of thing. Yeah,
no, I like that analogy. I think I'm gonna have to steal that from you. Rehab and regenerative medicine go hand in hand. This is fantastic. This is part of the process. I get to learn from amazing clinicians. That's why I like bringing people on here. So the kinetic assessment, I think you touched on a really, a thing that I believe that a lot, being sports medicine fellowship trained, I'm always looking for the aggravating factor, or what we can do to change that activity, right? The definition of insanity is doing the same thing over and over again, expect a different result. So if somebody's doing the same movement, same motion pattern, it's going to keep aggravating that same thing. So tell me a little bit about your kinetic assessment.
Right. Well, first we just do a quick gait assessment, and we look to see, there's what we call a gait cycle, and that basically from the point you lift your leg up to the point you push your toe off, we're looking at how your whole body is moving and how you're compensating. So for instance, somebody with a degenerative knee, osteoarthritis, typically medial compartment dominant degenerative process, we're going to see a lot of valgus in the hip, which is where the knee kind of turns inward. We might see a little bit of a Trendelenburg, which is kind of an altered gait pattern where you shift your whole body weight to the other side, basically to decrease the weight-bearing component of that knee. And then also we're looking at things like lack of activation of certain muscles, because certain muscles go hand in hand. I think you brought this to my attention, how important that gluteus medius is, which is a lateral hip muscle, yep, and how much it plays a role in stabilizing the medial knee. So sometimes we'll see some changes in the outside of the hip in terms of how they're moving the outside of their hip and how it impacts the stability on the inside of the knee. Yeah. So a lot of people go for bracing, but really all bracing does is feed into that problem.
Absolutely, and that brings us to like a really kind of rehashing exactly what he said. So really stability and looking at the assessment is the biggest thing, right? Understanding and looking at the root cause of the problem. I believe in functional medicine. If you find the root cause of an issue, when we start treating that and trying to build some more stability, you don't build it by putting a brace on it. You can put a brace on it for a temporary period of time, but that's just for a temporary period of time. I'm more of a fan of working with rehab and regenerative together to really help really re-emphasize and help stabilize that knee joint. And I like to call the knee the redheaded stepchild of the foot and the hip, right? It's kind of the one. It's the one right in the middle that really gets it. So I always have people take their shoes off. And they're like, Dr. Torrance, what do you have me take my shoes off for? Well, I go, listen, if you have flat feet or you have some, super high arch, we need to make sure we're addressing that in the in the swing and gait phase, right? So that's great to hear. I know when I talk to a quality physician, because they're a clinician, especially in therapy, because they're looking at those phases to try to change the root cause of the problem. So what modalities do you specifically go to? So I just want to let everybody know, we are in a kind of a knee arthritis section. And what can we do? So somebody comes in, they got some knee pain, some medial joint pain. A lot of times it's medial joint pain. And again, that's usually due in my book that I see a lot of is weak hips, weak glute medius, those kind of things. Now, what are some modalities that you can help with to help them get better? Because I'm a firm believer weight-bearing exercise helps with knee arthritis. But what else can you do in your book? And then when do they come to us? Sure.
Well, we're a hands-on profession, so treatment always starts with hands-on, whether it be assessment or actually treatment. So, for instance, you mentioned those tight hip muscles. So you really can't get down to the dysfunction in the knee unless you mobilize the hip, you mobilize the ankle, above and below. So a lot of times we'll work on proximal and distal joints, and then work toward the center. And depending on how irritated they are and what is irritated, so for instance, if they have a large synovial cyst, we might use some ultrasound. I'm a big fan of instrument-assisted soft tissue mobility, so we're working on scar tissue, adhesions, just general tissue congestion. So that's actually a manual therapy, but we use instruments to help get a deeper myofascial release. And then my go-to modality is...
Can I stop you there for a second?
Yeah.
Yeah. So I'm a huge fan of, instrument. So it's, another term for it is IA stim. I just want to talk to the audience and kind of cater to them a little bit. By the way, anybody wants to ask a question, they're happy. We're happy to field some questions here too. But one of the things is instrument-assisted soft tissue mobilization. So there's a couple different types of this, and that's something that you touched on. So I want to make sure we talk about A-stim is a technically branded way to do this. A lot of different places they use Graston. Graston's another terminology for this. Working on the IT bands, working on the glutes. They can use Graston tools. They're another branded tool system. Some places use, they use rock blades or, my other half, she actually teaches nationally for rock tape. So, she's got all the rock stuff. So she's got the blades and everything like that. And if you want any of those, I'm happy to get you some, stuff for popping on here tonight. I really appreciate it. And if you do any tape, I'm happy to get you some tape too. But
I'm Graston certified, so don't hold it against me. I don't want to have to compete with rock.
No, it's good. It's all good. It's all complimentary stuff. So Graston, A-stim, whatever tool. If it's a spoon and you're using it, if the clinician's putting their hands on you, that's a therapist. That's one of the biggest things that I look for in quality therapists is making sure that they're putting their hands on you. They're doing assessment. They're putting their hands on you and changing the tissue. But I don't mean to stop you. You were kind of. I just wanted to make sure we kind of diverge and make sure everybody understands what those other things are. Now you're talking about instrument-assisted ultrasound. What other things did you do?
Right. Well, back to the manual therapy. Obviously, we're looking at accessory joints, like if it's the knee, we're looking at the hip and the ankle. But also, if their primary diagnosis is osteoarthritis, they might have some more superficial issues in the knee. We see a lot of pes anserine bursitis, which is an irritation of a common insertion of the hamstring tendons. We might see patella tracking issues, IT band syndrome you mentioned, and that's kind of what I call the low-hanging fruit, which means we can really restore that movement dysfunction by actually focusing on things that are easier to fix as opposed to the harder stuff. Because as you know, osteoarthritis requires professionals like you to really remediate that condition.
Great. Now I'm just what I do when we're on here. I make sure that I field questions on my phone. So I'm kind of multitasking right now, and letting you talk about your stuff. So mobilization, instrument assisted ultrasound. What I think you use a little cold laser too, a little hot laser, cold laser. What else? I know you use some of that a little bit, don't you?
Yeah, so low-level light laser, which is really just the spectrum of light. Infrared light is been around since the 1960s. Okay. You see it every day at the grocery store, scanning your barcodes, but it actually can change the physiology of tissue. The challenge of infrared light is it scatters very quickly. It's an artificial spectrum of light. So you need a very powerful unit to drive it to deep tissue. And I really consider the knee joint, the condyle of the knee joint, the center of the knee joint, to be pretty deep tissue. So a lower watt laser device, we do it in classes, class 1, class 2, class 3, class 4. I have a class 4 laser. That's currently the highest certification you can have under FDA. Can pretty much get anywhere in the body. The only side effect is you have to be well trained so you don't create thermal injuries.
Yeah.
And by the way, it's very complementary to regenerative medicine procedures, the stem cells, the PRPs. I've read and shared with Dr. Torrance a number of peer-reviewed articles about how complementary class 4 laser is to, or low-level light laser. Again, low-level light just covers the gamut of the 4 classes. I use class 4 because, frankly, I think it's the most effective, but you also have to understand the dosing of infrared light, and I can get into that later, but dosing of infrared light is where the skill of a clinician comes. Anybody can apply it. Mm-hmm. with a little bit of training. A technician can do it.
Yep.
But the dosing is essential, and particularly post-procedural dosing. So whether it's a total knee or a stem cell procedure, how we dose that is super important, and that's why I offer it to your patients, because I know how to dose that for them post-procedurally.
No, and that's fantastic, and that's actually something that really kind of brings up an interesting, a great kind of knowing the technician, knowing the person who's doing this, and that's why I want to make sure that I'm working with a quality clinician as well, like yourself. Is that you also know that we're giving the proper dosing for regenerative medicine, and Regenix definitely prides itself in making sure that people know what they're getting, and that's something that whether it's PRP, PlateletRich Plasma, we call it super concentrated platelets because our company really uses a flexible lab platform, and we concentrate our platelets. So if if his conservative treatments aren't necessarily helping with the knee arthritis and aren't getting you where you want to be, a lot of times therapy can get you there. I'm a huge advocate for therapy. I think that rehab is something that it works before, after, and my one analogy that I like to use is that Tom Brady's with the Bucs now, so we can use Tom Brady. But probably one of the greatest quarterbacks of all time, whether you like him or not. I'm not a big fan of Tom Brady, but I appreciate his greatness. And he always needs a coach to make sure that he's watching him, making sure he's doing things correct. And that's the biggest thing I see with a lot of good rehab specialists. They're doing the correct things, or physicians in that mind, is that they're doing the things the right way, and that they're doing it the way that it's meant to be used, and that they're not sitting there and they understand what they're doing, right? Some of the worst players in the league, they don't understand why they're doing certain things. They just go out there and play, and they think that by them being the best player, they're gonna have a great team. But you got to work together as a team, and that's why we have a great rehab and rehab and regenerative team. Now, talking about that, so getting back to the PRP. So when we do concentrations, we know what concentrations we are giving to our patients. A lot of people in the regenerative field don't even know the concentration, and that's like somebody giving a medication and not getting the dosage, right? If I'm giving you moxicillin, I'm sure, hey, Dr. Korn, you're going to take amoxicillin, you're going to take it, and then you're going to feel better. Well, how much, doctor? How much? How many times? How many days? How many times a day? How long, right? These are all things that we need to know, and that's what it sounds like you're talking about with class 4 laser. You're giving the person the amount that you need to give to get them the best results. And that's the same thing with our dosing that we've learned through all our treatments and working with our patients. So I think that's a really good, what word am I looking for here?
Complementary.
Complementary, yeah, very complementary to what we're doing. So, all right, cool. So, all right, so these are some tools in the toolbox. Got a question for you. Are you going to be, or have you started doing, or have you done, or are you currently already doing dry needling?
It's funny that you said that, because my colleague, the other physical therapist that works with me, he is getting certified this weekend.
Fantastic.
And in the state of Florida, the acupuncture industry worked hard to try to not allow us to do that, even though they're very two different things.
Yes.
But I can understand why they're protective of it, and we don't want to encroach into their profession. But we're finally there. Florida is one of the last states that would allow us to do that. We just have to go through the certification and then observation. So he'll be certified, and then he has to get certain observation hours by another certified dry needling, and then I'll do the same, and that way we can do it under one roof.
Perfect, fantastic. So dry needling is a great, again, talk about changing the tissue, and that's what I see as one of the biggest things that we need to do from a clinician perspective. We went through all this schooling so we could lay hands on patients, and one of my biggest kind of qualms is that there's this whole pain science thing. I think it does work for certain things, but I think that changing the tissue and putting the hands on the patient is one of the biggest gifts that we've been given by doing all the training and all the certifications we've done. So that's something that I think that dry needling brings. You're changing tissue. You're changing tissue in an acute area to try to institute some new inflammation, which is very similar to very complementary to what we do as well. I'm putting a needle and I'm putting your body's most concentrated growth factors into an area of injury by precision guidance with ultrasound and fluoroscopy. And that's kind of where I'd kind of like to. I'll kind of drop off here. Give me a second. Let me grab a thing to wipe down. But let's kind of go back here. An assessment starts with looking at aggravating factors. For people just jumping on, we had about 4 or 5 people on here right now. But afterwards, if people want to come back to this, the kinetic assessment is the first thing a therapist at 65 plus is going to do for you. They're going to take a look, see what's aggravating things, and try to figure out some ways to change those. And then rehab and regenerative together works really well. But the treatments that Dr. Korn and his staff and team are going to do for you, talk about mobilizing. Do you do Mulligan technique at all for any hips or anything?
I'm more of a Maitland guy, but we do use some Mulligan strap techniques for some long axis distraction, which can be helpful in the hip and the ankle as well. But my philosophy is a little bit more toward mobilization, joint mobilization. In the Maitland arena. Okay,
cool. And then, we're talking about knee arthritis today. So we talked about above and below, the hip above and below, looking at the foot, making sure the foot's contacting things right, making sure that, I'm a big fan of, if somebody has a really bad, like plantar fasciitis, but pes planus, a flat foot for everybody. I definitely want them to get a little arch. I'm a big fan of super feet. It's a very low cost arch support that can help patients and put them in a little bit better position for contacting the ground with their feet. I don't know. What are your thoughts on that?
Actually, I have a pair of super feet in every single pair of shoes I own because they work and they're not overly expensive. And when they wear out, they're easy to replace. And they need just enough adjustment where there's not a big break-in period. So even people with significant arch collapse are going to find an immediate difference, and not just at the foot and ankle, but at the knee, the hip, the spine, all the way up the kinetic chain.
And that's what I was kind of drawing here, guys. Is that I'm just kind of drawing the foot, the knee here, the hip, and then kind of the pelvis. Not my best draw. I'm not the best artist, but you got the spine. So the spine goes up here. So everything that happens up this chain is going to affect the next joint up. And if you're not contacting the ground the right way, that's definitely going to be something that can be problematic. So do you have the sizing thing at your office or
for super feet?
Yeah.
I usually just direct them to the Superfeet website and say shop around like Amazon or Walmart or Target. You can pick it up anywhere. I'm not really big into resale of product, but what I have them do is when they do get what I ask them to get, they bring it in and we work on it together. Yeah. And I actually have them do some things with and without it. Okay. And they give me some feedback on how different they may feel. Or I might see that they're moving differently. And I'll even do some slow motion caption video on them. So a little gait analysis, video gait analysis is helpful for me as well. You slow down that gait cycle and you can pick up on very small details that maybe they can't appreciate right now, but after a full day of walking or a sporting event, it's really going to pay off.
100%. One of the places that I'll send people to, and just because I know that they have like kind of a sizing things like Fit to Run. Some of the running stores do a really good job with that. But if you're going to do the gait analysis, I'm happy to just send them to the website and have them pick it up and come see it. That makes it a little bit better. So just want to talk to Dr. Korn real quick. Let me clean this up real quick. So before I wipe this off, just want to let everybody know who's on here. We do see patients in St. Pete currently. I know this doesn't help Dr. Korn at all, but we see people in St. Pete. We're opening a full service office in St. Pete as of January 11th. We're working with Stacy Robinson. She's one of the functional medicine doctors. So she's having us, we're going to do a full-time office in our office. Currently, we're seeing consultations in St. Pete. So that's something that just wanted to make sure, kind of housekeeping to make sure I remind on this right now. So I want to have Dr. Korn real quick about what we do. And you know, him and I have, we've referred back and forth, but just talking about what we do for knee patients, knee pain issues. So first thing starts with we have a 60-minute evaluation. Okay. And, you know, so Dr. Korn, you know, most times you see people go to an orthopedic doctor. I'm sure they get about 5 to 10 minutes with the doctor. This is 60 minutes with me or Dr. Lieber. So that's our Sarasota office. You know, it's the closest one to where you're at. So I want to make sure that you know that any person you're referring to us is getting a 60-minute evaluation. And when that comes to knee, we do a clinical exam. Obviously, you know, history and physical, and clinical exam. And then after that, we're going to give them a diagnostic ultrasound. Okay. And so we teach, Dr. Lieber and myself teach for the IOF, the Interventional Orthopedic Foundation, which is a nonprofit that does a lot of teaching for orthobiologic treatments. And so when people come in, that's what the expectation for your patients is, so they know that they're getting a very quality exam. A lot of times we're going to show them things and we're going to show them an ultrasound and no, usually they're not pregnant. But that's my 2 cents on a funny joke. So diagnostic ultrasound, and you know, it really kind of helps to see and show a patient they're getting tenderness on that medial joint line. Is it really the meniscus, or is it the joint line, or is it some of the, you know, or is it behind the patella? You know, they have like that movie watcher sign when they're going to stand up after they sit down for like 2 hours. They got a lot of retropatellar arthritis, or they got some tracking issues. You can see the MPFL ligament. It's kind of like maybe like a little lax. So they're getting a little bit of lateral tracking. You know, there's a lot of things that have been going on there. So we're going to talk about what's going on there. And then after that, you know, we're going to give them a recommendation. And that's going to be based on, you know, what we see. Okay. Somebody with some mild arthritis, mild symptoms. It's actually, you know, I don't know if you know this, but I'm sure you do, but TRICARE is actually offering coverage for mild knee arthritis for PRP. So that's something to, you know, just kind of put in the toolbox and know that, hey, everybody's like, why isn't it covered by insurance? Well, you know, medicine kind of lags about 10 to 15 years behind what's actually working in the industry. And that's where we're kind of at right now. We also have corporate coverage for a lot of our patients. And so MarineMax is one of our corporate clients. ABC Wine and Spirits actually has Regenix procedures covered. So we're also getting, you know, we get more and more each day of some of these large corporations that, you know, St. Pete, the Diocese of St. Pete was actually with us, and they dropped off us, and we're trying to work that out. But so a lot of these large companies can elect to have us as a benefit to decrease the orthopedic spend. So I don't know if you knew that, but just want to kind of make sure that, you know, if you see anybody from those places, they have coverage by us. So
yeah, TRICARE is good to know, because obviously my demographic, quite a few vets. So
yeah. And Dr. Lieber is actually a vet himself, so we always try to make sure we take care of our veterans. Thank you for your service. But you know, these evaluations, though, they're usually covered by insurance as well. You know, you being 65 plus, you see a lot of Medicare patients. We take most forms of Medicare. There are some probably weird forms that I think everybody doesn't take, but that's a whole nother story. So that's exactly what we're gonna do. So we're gonna get the recommendation. And usually with, you know, mild symptoms, mild OA, I'll recommend to them PlateletRich Plasma. It really does very, very well. There's a lot of good evidence now that's coming out that's showing that randomized control trials, PRP versus hyaluronic acid versus saline versus, there's multiple studies now that show that it decreases pain, increases function, and that's great. So we're mild OA. If it's more of a moderate, so, you know, when we're looking at this, I don't know, are you familiar with you're probably familiar with the Kellen grade, Kellengren scale, like 1 to 4, right? This is usually a 1. Okay. The moderate would be like 2 to 3. And then severe, we're looking at, you know, grade 4. Usually this is in our bone marrow aspirate concentrate area. And the reason being is it's just, we've done a lot of studies on this. There's actually a new study that just came out that's done by Philippe Hernegow. He's out of Europe. He's one of the first guys to start doing regenerative medicine. Have you ever heard of his name?
I have not. I'm writing it down right now, though.
Okay. So Dr. Hernegow has been doing regenerative medicine for 30 years. He first started doing regenerative medicine really on hip, and it was more geared towards hip AVN. So for people who had had a lot of steroids and had AVN in the hips, alcoholics can have AVN in the hips. And what he has 30 years of data on treatment of AVN by putting BMAC into the AVN. Instead of doing like a core decompression, they do treatment into like the neck of the hip. But he just came back with a study that he did on 60 patients from 2000 to 2005, 60 patients in each group, right? Where they injected bone marrow concentrate into the joint and just into the joint, and then injected it into the actual bone itself. So when you look at the knee kind of looks like this. I'm better drawing knees than I am at the skeleton. So here we go. So the knee looks like this. All right, and I'm saying this today. All right, so we get your ACL that comes here. Get your MCL, LCL, meniscus in here, and so what Dr. Hernegow found out. So for people with particularly with medial-sided OA, a lot of times they get these like bone marrow lesions. I don't know, and you've probably seen this in some MRIs. You get some inflammation in the bone, right? Bad arthritis gets inflammation in the bone. And what he did was he did a study where he actually injected 10 cc's of bone marrow into the bone. And there were 60 patients who just did the into the bone, and there were 60 patients who did it into the actual joint. And the long-term data showed that only 20% of the people who got injected bone marrow concentrate into the actual bone would go on to a knee replacement in 15 years. So drastic reduction. I mean, about I think 50 or 60% reduction in pain, increase in function over that time frame, and only, like I said, 20%. So probably what I mean, that's four out of 5 patients would be able to tolerate and have good enough results with just bone marrow concentrate and bad arthritis. I think it was grade 2 and 3, and I think there's some 4s, but that's the data we're working with. That's the most recent data, and I think that's a pretty cool study to look at. It's always good to kind of sit here and talk to a clinician. I like to field questions too. So what do you have? I like to hear what questions you have for what we do, and what else we do.
So what do we see that I feel like you could possibly help with a consultation or, eventually a procedure if appropriate, are a lot of shoulder tendinopathies. As you know, it's just a wear and tear joint. There's a lot of shoulder instability, whether it be arthritis, but arthritis of the shoulder isn't really driving dysfunction unless it's end stage. It's mostly chronic tendinopathies, tendinosis, and I've seen a few of your patients with shoulder, and I'm very impressed. Beyond the knee, it's probably my second favorite thing to see coming out of your office, because I know they're going to be good to go. You're going to make me look good. So I like that.
No, yeah, and that's the shoulders are. So I would say the 3 things we see the people the most for are knees, lumbar spine, and shoulders. And shoulders really do fantastic. A lot of times, we're getting close to that time cutoff, but I want to kind of just make sure that I get to answer any questions you might have. So, a lot of times we're seeing some people that are pretty far along, right? I mean, like they got bad OA, and they really have a crappy rotator cuff. It's kind of I'd say a 50-50, 60-40 chance, like they're going to have a pretty good outcome. Now, if we caught it early enough, and so like mild to moderate OA, and we need to make sure we get that tendon. All we've had before is steroids, and you inject steroids into that bursa in the shoulder. And what are you doing? And they're doing it blind. So most of the times they're probably injecting the supraspinatus, and they're just contributing to decreased tendon strength, and they're going to cause weakness, and we're going to have to have a surgery in the long run. So definitely PRP and mild tendinopathy, tendinosis, small tears, they do fantastic with PRP, and I'm glad you brought that up. And if it's a bigger tear, larger tear, I like to say if it's greater than 25% tear, I'm going to definitely recommend, BMAC, because it does have a little bit more propensity for healing that tendon. But no, I'm glad you brought that up. What other questions do you have there?
Well, touting what you're doing here with the knee, the orthopedic surgeons are really getting away from meniscal surgeries because they're realizing the more meniscus they take out, the more they're advancing the OA. And I always joke with the orthopedic surgeons, I tell them, hey, that's insurance that they're your future patient again, because they do those meniscectomies, and then 3-4 years later, depending on their age, they're right back where they started from in worse pain. So that's where that PRP cut really comes in, because you're really trying to kind of give whatever meniscus is left kind of a new life. Yep. And it's to kind of keep that hyaluronic acid flowing through that joint, and so it doesn't dehydrate and just advance to the next stage of arthritis. So loving what you're doing in that respect.
Yeah, no, fantastic. Yeah, no, great point there. Clipping out this meniscus here, right? You can see it's like a triangular shaped structure, and it lives right here. So if you clip it out, you're essentially taking this and making these areas of the lateral femoral condyle here and the medial lateral tibial plateau. I don't know if you can see that well, but you're just allowing that to really kind of kiss and touch each other more often. And the more you have that, and it's not as good of a function. It's not as smooth as a movement, right? I mean, and that's really what we're trying to do, is we're trying to preserve tissue. We're I like to call us joint preservation specialists. Rehab and regenerative medicine, we're trying to preserve joints, because I know for a fact, after you have a knee replacement or after you have a meniscus surgery, meniscectomy is going to increase the chance that you're going to have a knee replacement, and it's going to advance that arthritis exponentially. But if you do like a PRP injection, a lot of times it's not an irreversible thing. Something that we know we have good results that if I inject with precision guidance, that's really a big Regenexx difference too, is that I'm going to use ultrasound and fluoroscopic guidance to make sure I put that right into the right tissue. And I think that's really a big thing.
Well, if we have the time, the last thing I wanted to say is that, there's that old saying, if you want a good cut of meat, take the butcher's word for it. Yeah. Not that I'm equating you to a butcher, but the point is that a lot of people pretend like they're into regenerative medicine. They look at it kind of like an ancillary revenue tool. Yep. And I just don't think you can be good at something like that unless you're doing it every day. Yep. And that's what I want to say about Dr. Torrance and Dr. Lieber, is that even if you question if regenerative medicine can help you, yep. You want to start with someone like Dr. Torrance to investigate the possibilities. And obviously, if you go down that route, just make sure you choose a qualified regenerative medicine specialist, which is what he is. He's just not on the corner, pushing PRP and doing a couple a month. And I think that's really important.
Well, thank you. No, I appreciate that. And that brings me to another kind of just rule aside. Chiropractors aren't supposed to be injecting into joints. A lot of times they hire people that are just trying to do this as an ancillary source of revenue. This is something that we're continuing to fight, because it takes somebody who specializes in this. This is all we do. We really refuse to inject steroids. And that's something that we know that derogatory effects of steroids. Now we're seeing that a rapid progression of arthritis in 1 out of 10 patients who get steroid injections to their knee. There's a lot of things that show that it makes bones weaker, right? Any kind of lumbar spine injections for any women over 50, 30% increase risk in compression fracture. These are things we're supposed to do no harm as clinicians, and really using your body's own cells is doing no harm. But I appreciate the vote of confidence, and that we're making sure that we're doing these things the right way.
Yeah, it's like your procedures are like 21st century steroids, because what they used in the 20th century is quite destructive, and I don't think it'll be used in the near future. If you want to write this down for your viewers, the acronym AGE. Okay. Just Google corticosteroids and advanced glycation end products. That's what AGE stands for. And basically, you're just, every time you get that tendon or bursa or whatever soft tissue structure injected, you're just taking years off of the structure of that tissue. And whether it's oral steroids or injectable steroids, it's not the way to go if you're looking to get more mileage out of your joints. Yep. So that's why I'm really into what you're doing.
Right on, man. Well, listen, we'll chat more next Friday. I'm gonna be making the trip down there. My daughter actually goes to school in Venice, so it's gonna be we'll have a good quality conversation. Hopefully, my fiance doesn't pop. She's She's 38 weeks right now. So
Oh, wow.
yeah. So
Well, I'll understand if you have to cancel last minute.
no. I'm not like I'm going to be there unless she goes into labor on Friday, which no, they're asking if they want to like they're asking if they want to strip membranes and stuff. Like, no, we cannot. But no, man. Well, listen, I look forward to continuing to work with you.
Get your sleep now, Dr. Torrance. Get your sleep now.
Do I sleep at all right now? I'm not.
Probably not.
I'm always working, man, trying to help people out. So listen, it's amazing. Thank you for working with our patients. I'm glad to work with you. And if you ever need anything, I look forward to seeing you and work with you in the future.
Thank you, Dr. Torrance.
Have a good night.
Be well.